than the number that they have done in a 6 months. I have seen also that the number of people who take the vaccine have increased by tenfold every single day compared to the period where they were using a fixed strategy. Just to share an example which shows clearly the effort that African government, the effort that is being made in the continent to increase the uptake of vaccines, which is, as I said earlier, the challenge and the undertaking which we have ahead of us, and for which we need to double down if we really need to catch up with the fact that we are so much lagging behind that this is really needed. Maybe I will keep it there, Fiona, and come back in a case question are asked on the situation in the countries I'm covering, or example where I can go into more in depth in the experience I have been seeing now being implemented here in Malawi. Back to you.
Thank you, Mr. Fall. That was quite powerful, and we are always glad to have you. Mr. Mohamed Omer Mukira Buzain, it's a pleasure to be with you today. Could you explain why mobilizing communities is so important for vaccine rollouts? Mr. Buzain, you're muted.
Thank you, Dr. Fiona. And I'm so delighted, and IFRC is delighted to share this platform with our partners, WHO and UNICEF, and to share this input with my colleagues, Dr. Muyoti and Mr. Muhammad Malik Fan. As I join you today for this important question about the COVID-19 vaccine in Africa, I joined this session partially guided by voices and lessons from some of the communities we serve in remote parts of Kenya, Isolo and Baringo counties. We recently have visited these two counties together with the Kenya Red Cross. And this visit confirmed that despite increased coverage of COVID-19 vaccine in Africa, a sizable proportion of those living in rural or hard-to-reach areas continue to be hesitant to receive the vaccines. There are several reasons for this hesitancy, as has been outlined by Muhammad Fall, as well as several possible solutions. But please allow me to single out three of these. Firstly, vaccine hesitancy is a complex problem which is also linked to livelihood of the communities. That is why we need to move beyond an exclusively COVID-19 focused response. The humanitarian needs in many parts of Africa are enormous. In Kenya, the Isolo County faces a drought crisis that is affecting thousands of people. To many people in Isolo, a much more urgent problem is hunger. It is hard to convince them to get COVID-19 vaccine when their next meal is not guaranteed. To effectively address COVID-19, we require a comprehensive approach that addresses not only the COVID-19 pandemic, but also broader health, food security, education, and other livelihood needs. To mitigate COVID-19's secondary effects, Red Cross, Red Crescent teams have distributed cash to vulnerable families in at least 38 countries in sub-Saharan Africa. Supporting and at least 43 Red Cross, Red Crescent national societies in sub-Saharan Africa are supporting vaccination programs in collaboration with their respective governments. Nearly 400 million people in sub-Saharan Africa have been reached by the Red Cross, Red Crescent COVID-19 response, including wide variety of responses and services, livelihood, cash distributions, in addition to supporting the vaccination as well. Secondly, this year we need to do more to gain community trust. Vaccine hesitancy is also caused by community mistrust. We need to invest more on risk communication and community engagement. When communities are in the driver's seat, they become vital contributors to finding solutions to the outbreaks of disease. Red Cross, Red Crescent teams across Africa have been at the front line of the response to COVID-19 since the beginning of the pandemic to build community trust and to address misinformation. Red Cross, Red Crescent volunteers are trusted community members, and they have successfully tackled hesitancy in several countries in Africa. South Sudan is one of the examples of success stories where improved community trust enhanced vaccine uptake and prevented vaccine wastage. Thirdly, better collaboration leads to better delivery of vaccines. We took a strategic step to tackle vaccine hesitancy in partnership with the Africa CDC and the MasterCard Foundation. The partnership provides a wide range of interventions, including provision of ambulance services, contact tracing, promotion of public health and social measures, while supporting preventive and control measures, as well as risk communication and community engagement in 54 African countries, including the North African countries. But a lot more needs to be done. Community-based actors can be a game changer, not only in COVID-19, but also broadly in pandemic and epidemic prevention, only if we invest more in them. Our network of 1.4 million volunteers across sub-Saharan Africa is in a good position to build up community trust in vaccines. The IFRC has asked for 146 million Swiss francs to leverage the power of this community network, but we have only received about half of that amount. With more funding, we will reach much more communities, and together with partners like UNICEF and WHO, we will work towards ensuring that 2022 is the year where COVID-19 vaccine program will be successful and the pandemic will be contained in Africa. Thank you, Fiona.
Thank you very much, Mr. Mukea Buzain, and for the great work that you and your team are doing, and IFRC all in all. Now that we've heard from all our panelists, it's your turn to ask questions. And as a reminder, please use the question and answer function on the Zoom application. And remember, you will need to provide your name and the news organization that you represent to have your question asked. And also for those who want to go live with your questions, kindly do let us know. We'll give you that opportunity. On hand, we also have Dr. Benido Impuma, the Director of Universal Health Coverage, Communicable and Non-Communicable Diseases Cluster at WHO Afro. We also have Dr. Richard Mihigo, the Coordinator of the Immunization and Vaccine Development Program. We also have Dr. Tieno Baldi, the Regional COVID-19 Incident Manager, on hand with us to answer your questions. The first question now will come from Paul Adepoju with the Lancet, and please, Paul, you can go live with your 1 to 2 questions. Thank you.
Okay. Good morning, and thanks for taking my question. So my first question is for Dr. Moeti and Mr. Mohamed for UNICEF. Last week at the executive board meeting of the WHO, Dr. Tedros indicated that COVID-19 will be here with us for a long time, even though he said it can be ended as a global emergency this year. So my question has to do with the long-term plan for vaccination exercises in Africa. What is being done in the long term, because UNICEF and WHO is also involved in several other vaccination exercises. So how is this the vaccination exercise for COVID-19? What is the longer term plan for it? We also heard about inequality also in testing, even though African countries are not saying they don't have adequate testing. The data shows that fewer testing per population is being done in African countries compared with the other parts of the world. So what is responsible for this gap, and what is being done to fill it? For the Red Cross, I have a question regarding, you mentioned in your statement about an initiative, cash for vaccines, in which families have been given some money. So can we have an idea of how much has been spent so far? And in the Tigray region in Ethiopia, I don't know whether the Red Cross has access, and how that has played out over the weeks, since we've had issues about response officers having restricted access to the region. Thank you very much.
Thank you, Paul. Over to you, Dr. Maweti, and then to
Yes, thank you very much, Paul, for those questions. Indeed, I think we all now have accepted that that COVID-19, this virus, will be with us for some time. It will be changing, adapting, new variants emerging, some dangerous in terms of pathogenicity, and some spreading very easily, as is happening with Omicron. So we need to have not only the urgent plans that are about to be put in place now to catch up, because we've been left behind in the African region or on the African continent in terms of access to vaccine supply. So at the moment, I think there is a really strong catching up mode, but with a recognition that this will be with us for some time, and we will need to adjust the planning for the future. And so what is going on now, I think, is an attempt to really mobilize all possible capacities. It was said by my two colleagues, both within the health systems of countries, working with partners in a very unique way, mobilizing all the capacities and changing our strategy to reach the people, and then very much working with communities themselves so that we create a demand on an ongoing basis. We do have experience of ongoing vaccine campaigns, certainly not at the scale of needing to cover this proportion of the population. We'll need, going forward, to understand who is most important to vaccinate. It may be that in the end it transitions into something that might be similar to vaccination for influenza, of which we have some experience in the future, and how to keep up the demand. But I think you are very correct. We are already trying to look for ways in which we can integrate and link the vaccine delivery with other ongoing services, and that will be part of the strategy going into the future. So indeed, our long-term planning has to go beyond this very intense campaign on which we are about to help our countries to embark now, to catch up, and then to carry on into the future, learning about the vaccine, adjusting our strategies, building on the experiences that we've had with vaccines that we're using in the long term. Then your second question about the low level of testing in African countries. Indeed, that's been one of the challenges that African countries have faced from the beginning of the pandemic, starting with when test kits and equipment supplies were very difficult to get at the start of the pandemic. And at the same time, we have to understand that the type of tests that can easily be used en masse in some of our health systems, the rapid tests, were being tested for their performance for quite a long time by WHO and other partners. So it took a while to be able to establish which are the rapid tests that are useful and that to be affordable and that can be used widely in the field. I believe now we have some tests that are like that, and we are working very hard to encourage our member states to use these tests so that they can carry out surveys to understand where the virus is circulating, as well as to test as needed for people with or without symptoms, and to manage the public health interventions of the pandemic. So indeed, testing needs to go up for different purposes in Africa. Rapid tests are increasingly being used, and we're very much encouraging this and supporting countries to have access to the supplies that are needed. Thank you.
Thank you, Dr. Maweti, and to you, Mr. Mukea, for the question that came on IFRC and access to some of places like Tigray. You're still muted.
Thank you very much. And please allow me just to give very short response to the long-term plan. We as a Red Cross Red Crescent, the 55 African national societies, we have a long-term plan, 5-year plan for pandemic and epidemic preparedness, including COVID. Part of that plan for us to strengthen the community health workers. So our plan to train 5 million community health workers over the 5 years and to put them in the high-risk areas of pandemic, epidemic in Africa. And that is hopefully, it will be support to facilitate to national governments and other partners such as UNICEF and WHO to make sure that there is efficiency and agility at that level of the community, especially the high-risk areas and the most vulnerable communities. Secondly, for the questions of the cash, we don't earmark cash for vaccines. We give cash for livelihood, and we leave it for the family to decide what to do with that cash. And I would say that about 30% of our plan and budget for the COVID-19 in Africa is actually allocated for livelihood and cash support. So the basic idea of the cash vouchers and the cash distribution is to give community flexibility in terms of supporting their livelihood needs. Thank you.
All right, so our next question comes from the BBC, from Emery Makumeno, and I'll give this to you, Dr. Richard and Mr. Fall. And Emery would like to know, is there any data available on the unused vaccines, and how many doses are being wasted due to vaccine hesitancy on the continent?
Okay, thank you very much, Fiona. Yes, indeed, working with our colleague in UNICEF, we are collecting information and data on the vaccine wastage in general. But I need to say that vaccine wastage, it's something we should not be necessarily focusing on and be too much worried about, because this is something that happened during any immunization drive. In a good planning for a campaign, we do account for a certain percentage of vaccine that could be wasted either before, during, or even after a campaign. And usually that threshold is between 5 to 10% in general. So to come back to specifically for COVID-19 vaccines, I think it's very difficult to disaggregate wastage that are linked specifically to vaccine hesitancy. I think we have heard from the three panelists that there are a number of reasons that are preventing population, are preventing people to access a vaccination site. So the combination of all of these different factors actually may lead to a vaccine wastage, and then not specifically targeting vaccine hesitancy. But indeed, we can disaggregate the information and try to understand that particular component, but it's very difficult to dissociate hesitancy among the continuum of the reason that could be leading to some wastage of the vaccine, as I've explained before, during and after a vaccination campaign.
Thank you, Richard. Mr. Fall, you'd like to weigh in here?
Yeah, just maybe to add a few words to say that I do agree with Dr. Richard that it's very difficult that we specifically say that vaccine was wasted because of hesitancy. I think we need to take into account also the fact that sometimes we have an issue of life shelves. For example, when vaccines arrive in countries with a very limited lifespan, I think it becomes a challenge for countries to use it on time. But I feel more and more, both in all the platforms are raising these issues, including the countries that are receiving the vaccines. And I think we are having less issues related to that very short life shelves. I think we are working together those data because this aspect need to be closely monitored. We haven't got them fully, but I'm confident that compared to the over 500 million doses received in sub-Saharan Africa, we are talking about less than 1% that has been wasted due to lifespans issues. And I would say also that with the issues that was and the activities that was highlighted by our colleague from IFRC, the example I shared from Malawi, indicating how governments, communities, health system is now stepping up their effort to expand the vaccination campaign. I'm sure that risk of vaccine wastage is going to be reduced. If a country like Malawi is now multiplying by tenfold the number of people vaccinated by day, just by using this express and this mobile strategy, it's a clear indication that moving forward, we will be seeing less and less vaccine wasted because of lifespans issue. I truly believe that the big question for the moment is to have the vaccines available in the continent, to have the funding that the government needs to have to be able to support the operational costs. I think if these two aspects and these two dimensions are properly addressed, I am seeing really a prospect where in the continent we will in a few months catch up with the delay we faced in the beginning of this vaccines campaign rollout. Back to you, Fiona.
Thank you, very optimistic, and that's quite encouraging. So our next question is from James Masharia Shege at Reuters. And these are the number of questions, actually. They go to you, Dr. Moeti and Mr. Fal. South Africa has changed its isolation guidance, citing that those who test positive for COVID-19 but have no symptoms do not have to isolate. Preliminary findings from 2 South African clinical trials suggest that the Omicron variant has a much higher rate of asymptomatic carriage than earlier variants. Now, to you, Dr. Moeti. Scientists have said we are still in a pandemic and not endemic mode. Do you think the new rules in South Africa suggest that we are approaching endemic status in that country? And what is your take on the decision by the South African government?
I think all governments and countries are navigating the various needs in relation to the response to the pandemic as we learn more and more about the virus, how it spreads, and its impact on people. So I think it's very understandable that in seeking to reach this balance, countries are working on normalizing the response while managing the risk. And the risk we need to remember is that we really would like to prevent is having severe illness among people who are most vulnerable, overwhelming our health systems, and then having a negative impact, negative sort of runoff impact on health systems in general. So if in an effort to balance all of this, including on people being able to continue with their normal and economic activities, we have understood that the current variant is less dangerous and people understand the public health measures that they need to take. There may be some justification for countries to start to ease the duration of isolation if people are not ill, to enable the other side of things to happen, life to normalize. We've seen that being done in a number of countries in addition to South Africa as well, some of which have reached a certain level of vaccination of their populations, meaning then these people are unlikely to become severely ill even if they acquire the vaccine. So for us, it's something that needs to be attempted by countries. It needs to be, and I'm certain it will be very much guided on a continuous basis by the data on what then happens after shortening the period of self-isolation. Does it trigger a certain trend in terms of transmission and severe illness? If it does not, this is progressively bringing us to normalizing and living with the COVID-19 virus in a way that we will need to do in the future, all signs indicate. So we will monitor how this is working in our countries as well as at the international level and be able to therefore adjust our advice to other member states based on experience like the South Africans are embarking on now. Thank you.
All right. In the same context, Mr. Fal, the regulatory provision for social distancing of 1 meter for learners in schools in South Africa has also been removed. Is this throwing caution to the wind?
Thank you very much. I think we have to keep one principle, and I am sure on this, my sister, Dr. Moiti could speak to on the guidelines that need to be maintained. I truly believe that we need to maintain those measures. And as you know, we were one of the biggest advocates for school to reopen because we felt that the benefit for children to be back to school was really largely overweighting the fact that we keep them thinking that they are super spreaders. I think there was scientific evidence at that time showing that the impact of reopening school on the trajectory of the pandemic was not that as great as maybe sometimes presented by information which were not grounded on scientific data. Now, when we talk about reopening school, I think international partners like World Bank, UNESCO, UNICEF provided also guidelines under which we think that safety measures should have been put in place. And part of those safety measures was that we minimize the number of students in a classroom to allow for social distancing within the context of the learning, to measure temperature of the children, to put hand washing facilities that could allow children to wash their hands at any given time in the learning environment, and at the same time advising to the use of masks in the context of classroom. I think this has been used widely. I don't know specifically that case which was referred to in the context of South Africa, but I can tell you that throughout the response to this pandemic, we have seen one by one country reopening school, and the last one has been the last month in Uganda, which also was very much welcome by the student, the parents, the teachers, and we haven't seen any kind of peak or any kind of surge that could be linked to the fact that school was reopened. And I want to continue to believe on the data and on the scientific evidence, to continue to believe on the fact that reopening school largely overweight what we gain by keeping them closed, mainly in terms of loss in opportunity of learning, the mental health it raises among children, the pressure it puts on the parents, and also the way it exposes children to further abuse. I learned recently that in countries like Uganda, we have recorded an additional 300,000 girls who have been impregnated during the lockdown of school. This is striking. This is a crisis for me. And I think that's why we will continue to advocate for school to remain open for the benefit it has for children, for learning and addressing the learning crisis that our countries were facing prior to COVID, but also for the safety and for the well-being of children with all the respect, mainly with regard to avoiding further exposure to abuse or to exploitation, as we have seen the devastating consequences, as the example I have given just now on Uganda. That's what I can say, and just continue. And we count, by the way, on the media also to continue to support us by spreading the right information to the education community and the need of putting safety measures in school, but also on the need of maintaining school and arguing that, you know, the benefit of maintaining school open always overweight the risk that we have by keeping them closed. Back to you, Fiona.
Quite some important information there. Thank you, Mr. Fall. Our next question is going to Dr. Nixie Gumede, the regional virologist with WHO Africa in the African region. And it comes from Elizabeth Merab of Nation and Bloomberg. And Elizabeth would like to know, what is the status of the 0.2 Omicron sublineage in Africa? Which countries have reported cases, and is there a likelihood that cases could rise on the continent? Over to Dr. Gumede.
Thank you so much, Fiona. And my apology, I really had some technical glitches due to the load shedding here in South Africa. Out of the three sublineages of Omicron, we know that we've got BA1, BA2, and BA3. So far, we have seen quite a number of cases that are linked to BA1. BA2, which is also known as the stealth Omicron, has been reported in 5 countries, that is in Botswana, Kenya, Malawi, Senegal, as well as South Africa. And the numbers of these cases are quite very low compared to the numbers of the BA1 sublineage that we have seen in the African continent. However, we are very concerned. Just to take you back from the beginning where we were putting all the criteria of identifying or screening the Omicron itself. At the time, we were more focusing on the fact that those samples or those viruses that are undergoing the diagnostic PCR, they might also show what is known as the S gene target failure. And the latest information from the researchers globally, they've seen that the BA2 now is having a tendency of escaping that criteria that was given previously. So as WHO, we have put some preventative action and also working very closely with the laboratories that even if the sample is not showing any target failure that has been used before to screen out to BA2, those samples that are supposed to be forwarded immediately for sequencing. So we can see the data for BA2 in the region being very low, but we are having a little bit of a concern that we might have maybe missed some of this BA2 in some of the samples that were screened previously. But we are working with the labs and we are really emphasizing to them that they really need to forward any Omicron or any samples that has been tested positive, forward it immediately for the sequencing. Over to you, Fiona, thank you.
Thank you, Nixie. So the next question, we have questions from Lindsay of New York Times, and I will ask the first one to you, Mr. Muke Abuzain, and then the following questions will follow to Mr. Fall and also to Dr. Moeti. So the first question to IFRC, what are some of the main obstacles to delivery of vaccines on the continent, particularly in urban areas, urban more densely populated areas where one would imagine healthcare may be more accessible?
Thank you, Dr. Fiona. I think in our experience, as I've said earlier, there is combination of reasons. Number one, the logistics. We discovering that because of the weaker health infrastructure, sometimes is not possible for government, and we're trying our best to help in terms of logistics to deliver the vaccines, especially in urban and slums. Let me put it this way, in the big cities in Africa. That is one key reason. The second reason we are finding actually for us with our volunteers, we try to help the government, normally Ministry of Health, on community mobilizations in issues of the hesitancy, but also the issue sometimes to help in public service area, especially in the marginal areas when there is immigrants, where there is disabled people, etc. And we found also these categories of the most vulnerable people, especially in urban and slums, are not well covered and reached by the government. And we are focusing on that to make sure that the most vulnerable categories, especially in cities, we support them, we bring them out, and we give them the whatever support it takes, logistic support and other support for them to access the vaccination and the service. Thank you.
Thank you. And now over to you, Mr. Fall. Why are African countries receiving vaccine doses that are close to expiry?
You put me on the spot on this. What I feel is that I think Dr. Moeti spoke to it in the beginning by saying that we have gone through a kind of trends, which is where we observe, different stage. In the beginning, as we all remember, there was a time where there was a huge inequity in the distribution of the vaccines. And then the campaign started, and then the supply chain also of vaccine was constrained. You remember when there was a big surge in India, the Serum Institute of India, which was one of the main suppliers of vaccines, of Covishield, at some point had to interrupt its supply. And it put challenges on many African countries. I think the rush of maybe speeding up the vaccination program in Africa, given the delay we had compared to the rest of the world where vaccines was really surging and taking a certain speed, maybe put or place people in a position that for the sake of maybe starting the campaign or increasing number of people who have opportunity to be vaccinated could maybe make them think that, yes, we could maybe take these vaccines with the optimistic scenario that maybe with a limited time of 3 weeks, 1 month, maybe 6 weeks, we could absorb them. And later on, when the implementation starts, some of the challenges that I referred to earlier, which was related to the operational cost and the operationalization of moving from vaccines to vaccination was discovered. And the challenge that and the pressure it puts on the health system in terms of availability of cold chain, availabilities of health workers to administer the vaccines, engaging with community and increasing the demand of vaccines, all those challenges probably came on the daylight when we start rolling out and implementing the first phase. And it's based on those learning that in the conversation, we start also saying that it's true that we need to catch up with the number of vaccines available in sub-Saharan Africa, but we cannot do it at all costs. We need to do it also taking into account the absorption capacity and the requirement to increase that absorption capacity. And I think that's how we could see that in one hand, governments and partners were stepping up their ability to implement and roll out the vaccines, but in the other hand also, countries who was donating vaccines were also being much more realistic in what is feasible in terms of absorption once the vaccines comes to sub-Saharan Africa. And I think this combination of these factors are showing clearly not only the increase, the absorption is now increasing, but at the same time also the number of doses that are lost because of life shells, as I say, are being minimized. So we don't have the specific or the exact number, but one can say surely that it's really a minimum number of doses that have been lost. And with time, we are seeing also that loss being almost inexistent compared to the first month where we have seen here and there few thousand of doses of vaccines lost or wasted. I think we are in a time where I haven't seen in recent news any issues related to that wastage of vaccines that we said earlier. I don't think it's a willingness. It's also a process through which we are learning. And as I say, this vaccination rollout is 5 times higher than what we used to do under the routine immunization program. And the curves, of course, goes with learning. The learning curves can be also sometimes steep. But what I can see is that every single day is coming a learning based on which we are improving the operationalization and we are improving the rollout as I'm seeing it in the field. Back to you, Fiona.
Thank you, Mr. Fall. Now to you, Dr. Moweti. Now that, again, this is from Lindsay with New York Times. Now that Omicron has proven to be less severe and other parts of the world that are talking about learning to live with the virus, do you worry that this will decrease the urgency to get vaccines to Africa?
In a word, yes. Not only to get vaccines to Africa, but for people to want to be vaccinated. So for the demand, I think we already are seeing signs that people's understanding is that, yes, this virus is spreading very fast, but in fact, it's not very lethal. And therefore, it might be that some people feel, why would we bother? It's a variant of the virus, which is not very dangerous. So we need, in order to sustain the interest of people to be vaccinated, to get us to the place where we can normalize life, we need to have people aware that, you know, if we get a combination of the Omicron variant that is very transmissible, because the virus is changing all the time, there are new variants emerging all the time, with a variant that is more lethal, then we could be in a very dangerous situation again, with more people falling ill, with our healthcare systems being overwhelmed, and with then the need rising again to get back to lockdowns, to stopping this. So for me, it's very, very important that we indeed acknowledge with some relief that we're seeing that this variant is not very lethal, but that does not stop the need for us to vaccinate people, to protect particularly the most vulnerable, and to continue where necessary with the public health measures, because the viruses are changing all the time, and it could there could be a variant emerging on top of the Omicron that could be much more lethal.
All right. Just to let you know that we'll compensate for the time we lost at the beginning. Now over to you, Yusuf Ba from Al Jazeera. Do you want to go live with your question?
Yes. Yes. Good morning to you all. My question is for Dr. Moti. As I said, what is responsible for the death of COVID patients who have taken the COVID vaccine? Don't you think because of the COVID vaccine deaths, let me call it this way, and this is responsible for the reluctancy of people who are refusing to take the vaccine, especially in my country, people are refusing to take the vaccine. What are the reasons that are responsible for some of these deaths of people who have taken the vaccine?
Okay, Dr. Mihigo, would you want to take that question?
Yeah, thank you, Fiona, and thanks to the colleague. I think we need, first of all, to put things into perspective. I think when we are looking at the data that we are currently, and we are getting more and more information, I think on the cause of people who are dying, I think if we looked at the profile, I think most of the people who are getting seriously ill or unfortunately are dying, in big majority, people have not been vaccinated. I think this is really one of the strong message that we need to put out there. And it's true that, and particularly we have seen it with this Omicron wave, that people were either insufficiently vaccinated or even sometimes even fully vaccinated also do get infected. But the good news is that, and now there are robust data that is supporting this, people tend to develop very mild form of the disease. So the current vaccine are really providing robust protection against severe disease and hospitalization. Having said that, we still do have few cases, and this is rather the minority of people who can have fully vaccinated and could unfortunately die about that. We need to remember that the pre-existing condition of the people who have been vaccinated will also play a major role in the outcome of the, unfortunately, when people get infected. So I think in conclusion, we could say that vaccine, yes, still and are protecting people against severe diseases. And I think we need absolutely to sensitize people and to pass this message on. And those who are getting vaccine tend not to do the form which are going to lead them to hospitalization. And for those who unfortunately will die, I think this is where also our case management, our colleague working to strengthen the system are also putting a lot of effort to make sure that people with pre-existing condition and etc. Beyond vaccination and beyond being taken care of can also receive the necessary care that they need.
Thank you, Dr. Mihigo. And we have a question from Sandrine Batan from Le Monde, and I will give this first one to you, Dr. Tieno Balde. What conclusions can be drawn from the survey on seroprevalence conducted in Gabon that shows that on 26 January this year, 86.6% of the 3,455 people tested have been in contact with the SARS-CoV-2 and developed a natural immunity to the virus?
Thank you, Fiona. Indeed, we have seen this study, and this study has been also supported by the World Health Organization, as many other studies, since the beginning of this pandemic. The World Health Organization has really supported many countries, and especially, in Africa, about almost 11 countries for conducting 40 studies, these seroprevalence studies, in order to know exactly how far people have been really in contact with this virus. And the result which has been, highlighted in Gabon, are those figures as you rightly mentioned. But we really also to keep in mind that there might be some kind of, heterogeneity, in this result, even within one country, because there are differences, in terms of the contact of the virus at the urban areas, in rural areas, within a different group of the people. So definitely people have been in contact with the virus. And when we have a kind of regional perspective, what we have seen currently is this seroprevalence is really vary, from almost 3% to 60%, in all of our region here. I think one of the most important elements that we have to bear in mind here, yes, for sure, the natural infection can provide a certain level of immunity, but that immunity cannot last like the one for the vaccination. And also, as we were hearing from the other colleagues here, the vaccination, can really allow us, to avoid the severe, form of the disease. While if you got infected, if you are having, you are asymptomatic, or maybe you are only mild symptoms, the level of immunity can really vary. So just to conclude, definitely for getting, the immunity, which can really preserve you and protect you, for getting, severely ill and probably maybe leading to death, it's really the vaccination. Thank you, and back to you, Fiona.
Thank you, Balde. Over to you, Dr. Moeti, to also weigh in on these last two questions.
Thank you. Thanks very much, Fiona. I wanted to add something on to the Nigerian colleague journalist who indicated that people believe that people who get vaccinated die. So on the one hand, of course, I think Richard answered very much that we've seen that people who die of COVID-19 tend to be people who are unvaccinated. But there are people who fear to be vaccinated because they think the vaccine itself is going to kill them with adverse effects of the vaccine. So it's very important to indicate that most people who get vaccinated get a mild symptom of pain in the vaccination site, fever, tiredness for a day or so, and then recover. There have been some reports of severe adverse effects from the vaccine. I think we can't get away from that. But the most important thing to emphasize is that these are extremely rare events. These are really very rare. There were worries at the beginning about severe allergic reactions, about blood clots in the lungs that some people might get. And just to emphasize, yes, we have adverse effects from all vaccines, but of the hundreds of millions of people that have been vaccinated worldwide, very few people have had these adverse events. So in communication with the population, I think our message should be to reassure people. We've now vaccinated all over the world way too many people for this not to have been a big problem that is being ignored. We'd like to encourage people to come forward and be vaccinated, exactly so that if they do get infected with COVID-19, they will most probably not die of it, because this is what the experience has shown. Thank you.
Thanks for clarifying that, adding more information. Dr. Moeti, as we wind up, we have just a few last questions. And this next one comes to you, Dr. Benido Impuma. Must Gabon and the continent continue the same vaccination strategy, targeting 70% of the population, or should we rather target people with higher risks, such as health workers or the elderly, and those with comorbidities? That's also in line with what Dr. Balde was talking about.
Thank you, Fiona. I think our recommendation as WHO is really, in terms of vaccination, to start with those who belong to the highest risk groups. So these are people beyond, for instance, 60 years old, those with like immunocompromised conditions. So that should be like the first priority. And then once we reach a set target for those specific groups, we can now look at the other groups. So that's something we need to consider. Just also to say that despite the fact that the seroprevalence survey was conducted, we are in a situation where we are still seeing cases and deaths attributed to COVID-19. So it's still extremely important to make sure that we can bring at least the acute phase of the pandemic under control before starting envisaging relaxation of some of the public measures. Over, back to you.
Thank you, Dr. Benito. So we have our last question to you, Mr. Fall, and it's from Chinedu Asadu from Associated Press. How effective have vaccine mandates been in boosting vaccination rates in Africa? And have you seen any pushback from populations and laws?
Thank you so much. Thanks, Chinedu. I don't have really specific figures or data on countries that have made vaccines mandatory or what has been the reaction of the people, but we have seen it also in other countries like in Europe with sometime government enforcing measures, putting them in place and trying to find a way to enforce them. Sometimes not just making them mandatory, but sometimes just requiring the pass for accessing to certain services, including the public services. We have seen also that sometimes it has triggered a kind of reaction, which is building up in many countries, and to a certain extent, reinforcing even the anti-vaccines movement. What I can say is that what we prioritize in the context of the country we work in, it is to make sure that wherever you have hesitancy, there is the community engagement, there is information, there is also the communication that support and respond to the question or to the queries that the people who are hesitant or who are reluctant have. And as I say, I have given at length example where I have seen the big change that this community engagement and this communication engagement are helping to address in many countries. I have spoken about Malawi, where I'm currently, but I have also example where I have seen in countries like South Sudan, for example, where we have seen in the beginning, the uptake was very low among female population due to misconception, misinformation around the possible impact on pregnancy, the possible impact on fertility. But with those engagement through radio, talk show, through face-to-face communication, we have seen significant change and an increase of over 55% of the uptake between September 2021 and the end of the year, just thanks to those kind of engagement. I would think that this is the way to go. For sure, there is also a need to better understand what the hesitancy, the reason of the hesitancy. Is it based on just pushback on the vaccination, or is it based on misconception or misinformation? And I think we are doing also increased effort in having those data and disaggregating them. And by the way, we see also sometimes this hesitancy even among health workers. And I'm seeing that in many parts of the continent, in the beginning, the uptake among health workers were low, but with this kind of engagement, we are seeing a steady increase. And I would think that those are the way that we need to prioritize. Of course, governments are sovereign. Government can take those measures. We have seen in countries where now it's a requirement for public health. To a certain extent, it's helping to boost the uptake. I can see it. I live in Kenya. I know Kenyan government have come now with a requirement to show vaccine status to access to a certain public places. Many other countries have done it. But I think that's what we need to do. And in this endeavor, we should also avoid that the whole debate and the whole issues around the uptake of the COVID vaccines spread a negative consequences on the hesitancy around vaccination in general. Let's not forget that vaccine has come out as the proven mean and the tangible mean of reducing child mortality in the past decade. It has been proven as the most effective and most efficient public health intervention that has been known so far. And I don't want also this conversation around hesitancy or around anti-vax movement open also a door for an expanded push against vaccination. And we always need to keep this in mind while we engage in this COVID vaccination rollout. I don't know if I responded specifically to your question, but that's what I wanted to share as the data are available or information are available on what we do with governments to address the issues of evidence hesitancy. Back to you, Fiona.
Highly appreciated, Mr. Fall. So we are coming to an end of this virtual press conference, and now let's turn to our panelists to hear any final messages. Just as a reminder, you each have a minute. I'll start with you, Mr. Mohamed Omer Mukir Abuzain, the Regional Director for Africa for International Federation of the Red Cross.
Thank you, Fiona. Two brief messages. Number one, trust deficit. I think we need to work on the trust deficit between the public and national governmental services, and to make sure that people believe into vaccines and that vaccines are one of the key solutions for the pandemic. That is one. Number two, the issue of funding. I think what I hear, not only myself as Red Cross, Red Crescent, IFRC, but from UNICEF as well, that the lack of funding to allow governmental authorities and to allow all of us to provide the services in a comprehensive way, vaccines, social and livelihood support to people affected by COVID, that's important as well. Thank you, Fiona.
Thank you very much. And again, we're happy to have you there. Now over to you, Mr. Mohamed Fall, the Regional Director too for Eastern Southern Africa, UNICEF Region Office.
Just maybe to reinforce two messages. One is the funding for the operational costs, and it needs to match with the increased allocation and donation we are seeing toward the African continent. That's the only way we can move from vaccines to vaccination. Look at also when the allocation are made, the life shelves of the dose that are given, because also putting it at a very short time wouldn't allow the turnaround that is needed to avoid wastage. And lastly, an optimistic note to say that if there is any continent where people are familiar with vaccination, it's Sub-Saharan Africa. Let's not forget that less than 2 years ago, we celebrated the eradication of wild virus polio in our continent. This was thanks to the effort of the vaccination, which involved government, community leaders, community workers, development partners, including WHO, Gavi, UNICEF, all of us. And I think we have got enough skills, knowledge, capacity, and network to rise to the challenge that we face today. It's just that additional push in terms of availability of vaccines and additional resources for the operational cost we need. But I'm really optimistic for the acceleration of the vaccines program in our continent. Back to you.
Thank you, and for sure we can make it. And as I turn over to you, Dr. Moeti, in your closing remarks, if you could address this question from Chukwuma Mwanya from the Guardian paper in Nigeria. Why is Africa, especially Sub-Saharan Africa, least affected?
What, sorry?
Why is Africa, especially Sub-Saharan Africa, least affected by COVID-19?
Okay. Thank you very much. First, to respond to the question, we think there are many factors why we have seen a much less severe situation of COVID-19 in Africa than had been expected. If you look at the way the virus is transmitted, how it has moved into countries, it's several things. One, the international connectedness of Africa is much less intense than many other countries. If you look at what have been some of the worst affected countries at the early stages of the pandemic, it was very much South Africa in the south, which is very connected, and some of the North African countries. If you look at the number of international flights per day in some of the countries, in some countries, they are really very minimal. So first, the way the virus came in. Then secondly, we have a largely rural population. The virus has stayed essentially around urban areas, and we still have a majority of African people living in rural areas where people are living in the open. The concentration of the population is less. And then in terms of severity of illness, death, we have a relatively young population in Africa. Even if people have gotten infected, that proportion of the population that's very vulnerable has pre-existing conditions that make people vulnerable to severe illness is less in Africa. Having said that, I think we must understand that the economic impact due to some of the measures that had to be put in place has been very severe in Africa and is going to have spin-off effects then on health, on education, on development. So we cannot say that our continent has gotten away with it. This is what I'd like to emphasize, simply so that now transitioning into what we have to do with the vaccination opportunity. First, just to conclude, I'd like to thank very much my fellow panelists, colleagues who have joined us for your very rich contribution to our discussions, and to thank the members of our team who joined us. And to say a couple of things finally. We're poised on a very great opportunity after very difficult times for a year and a half in terms of access to vaccines. And we are advocating strongly, I'd like to add my own voice around the funding. We're used to carrying out vaccination campaigns in Africa. And this time, the expectation is that we will have international solidarity, and encouraged by what our members, our leaders at the political level have been doing, we'd like to encourage them as well then to take the next step in terms of accessing some of the financing that's available internationally from the World Bank, from the Afrexim Bank, so that the money is there as the vaccines are arriving for the operations. That's very, very important. And then secondly, I'd like, ending on a positive note as well, to celebrate the partnerships that have been mobilized around the delivery of vaccines and response to the pandemic. It is very important that we all work together, different UN agencies, civil society organizations that are at the community level, the private sector, and the role that it can play, and very importantly, again, centrally, communities. I'm quite certain that if we communicate through the right channels, through the right people, we can overcome much of the vaccine hesitancy and have our people ready to play their part so that we vaccinate the population. Thank you very much. And sorry for having gone over my allocated 1 minute. Thank you. Over to you, Fiona.
Thank you very much. No, thanks, Dr. Moeti again, and all the panelists, and to you, our journalists and members of the media, for always joining us. We don't take it for granted. So we've come to the end of this session. Please remember to stay safe. COVID is still with us. And remember to each of you get your jab. As we wind up, we shall have a French session that will have Dr. Richard Mihigo that will stay behind together with our French journalists for any extra questions. Thank you and have a very good day.
Thank you, Dr. Atwebe, et bienvenue à tout le monde. Cette session entièrement en français de la conférence de presse de l'OMS Afrique. C'est une session qui sera courte. Nous avons deux questions donc, qui sont, que j'aimerais adresser au Dr. Richard Mihigo. C'est une question de Ryan Nziengu de la télévision nationale du Gabon. La première question concerne la distribution des vaccins contre la Covid dans le monde. Est-ce qu'ils sont coordonnés en fonction des besoins ou sont-ils laissés à la discrétion de chaque État? À vous, Dr. Mihigo.
Okay, merci beaucoup. effectivement, on a essayé d'aborder cette question même dans la partie anglophone de cette conférence. Ce qu'il faut comprendre, c'est que, comme vous le savez tous, nous avons malheureusement, nous sommes passés par plusieurs étapes dans l'approvisionnement des vaccins au niveau de la région africaine. Comme vous le savez, au début de l'année 2021, lorsque les vaccins ont commencé à être distribués, la plupart des doses qui étaient disponibles avaient été malheureusement accaparées par les pays qui avaient pu payer à l'avance. Et la situation s'est un peu, je dirais, aggravée avec l'apparition du variant Delta qui avait affecté longuement l'Inde et qui avait suspendu l'exportation des vaccins, particulièrement le vaccin AstraZeneca, pour se concentrer au marché local en Inde. Ce qui fait que, malheureusement, la plupart des doses qui étaient disponibles entre avril et le mois de juin-juillet, de manière globale, étaient distribuées en fonction de la disponibilité des doses qui s'est trouvée sur le plan global. Par contre, depuis quelques mois maintenant, nous voyons une certaine amélioration dans la quantité des vaccins qui deviennent disponibles au niveau de COVAX. Et l'initiative COVAX vient même de changer de stratégie pour cette fois-ci privilégier non pas une approche où les vaccins sont envoyés au pays sans leur accord, plutôt sur une approche approvisionner les pays en vaccins en fonction des demandes de chaque pays. Donc, au mois de janvier, nous avons clôturé un exercice où chaque pays avait été demandé de clarifier quels sont les besoins en vaccins pour les prochains mois, de manière à ce que les distributions des vaccins puissent cette fois-ci se faire de manière coordonnée et en fonction des besoins exprimés par chaque pays. Voilà un peu la nouvelle stratégie, la nouvelle logique que nous allons, pour le moment, mettre en œuvre dans les jours et les mois à venir.
Merci beaucoup. La deuxième et dernière question concerne la fabrication de vaccins. Est-ce que l'OMS soutient l'idée de fabriquer des vaccins contre la COVID-19 en Afrique?
Non, absolument, hein, absolument. Nous avons vu, effectivement, par rapport à ce que je disais, Vincent, qu'il y a eu plusieurs facteurs qui ont limité l'approvisionnement des vaccins au niveau de la région africaine. Et un des facteurs, c'était l'absence quasiment des structures sur le continent africain qui pouvaient effectivement fabriquer ces vaccins. Mais les choses ont complètement changé. Il y a eu une prise de conscience importante dans la plupart, surtout au niveau du continent africain. L'OMS en particulier travaille avec l'Union africaine et les pays pour effectivement les aider à essayer de mettre en place des structures de production de vaccins pérennes sur leur continent. Nous avons le hub de transfert de technologies, mais également des formations que l'OMS appuie en Afrique du Sud, mais également plusieurs autres pays qui ont exprimé ou signé des partenariats de production locale de vaccins. C'est le cas du Sénégal et le Rwanda avec, par exemple, la firme BioNTech, mais également en Afrique du Nord, des pays comme le Maroc, l'Algérie et l'Égypte qui ont déjà commencé à produire un certain nombre de vaccins avec des licences chinoises. Donc, nous avons beaucoup de choses qui se passent aujourd'hui et le continent, il y a des initiatives qui bougent pour la production locale des vaccins au niveau du continent et nous sommes derrière, en fait, pour appuyer et accompagner les pays dans cette stratégie.
Merci beaucoup, Dr Richard Mihigo. Je rappelle que vous êtes coordinateur du programme de vaccination et de mise au point des vaccins au bureau régional de l'OMS pour l'Afrique. Merci aux journalistes francophones d'être restés un petit peu plus longtemps avec nous. Nous espérons vous voir la semaine prochaine. Merci beaucoup à tout le monde. Bonne journée.
Merci.